Hey, Joanna, can you see the slides now?
Yeah.
Okay, good. You can see the flickering.
You can.
Okay,
Do you want me
good.
to tell you what I see?
Nah, I trust you.
Hmm.
So it should be fine.
Yeah, it's just slides.
Yeah, that's perfect. I'm just waiting for Rohit to come back. We can do some checks and we're good to go.
Yeah, perfect.
Mr. Rohit.
Rohit is not in at the moment.
Okay. So the thing is, I wanted to share the CV slide and just wanted to check if that can be seen and if I'm audible enough for the audience. Is that okay? Can I share my slide once?
Sure, you can do it. But yeah, obviously only one person can share, so it will cut this off. But yeah, you can share. I'll share again afterwards.
Okay, let me try. Thank you. Hello.
Yeah, we don't see anything at the moment, just so you know.
Hello. Yeah, I'm sharing. One second.
So do you plan to share these slides at some point during the webinar? Can you hear me?
No, not actually. This is only the CV slide. I will be introducing the moderator and then she will be taking it forward. So only 2 CV slides that I will be sharing and then it will be taken ahead by your side only. I mean, then you all will be only sharing the slide.
Okay, then Ashwin, we will need you. You will need to stay there, yeah?
Sorry?
I'm sorry, I'm talking to Ashwin.
Okay.
All right, yeah.
एक मिनट.
Hello, can you hear me?
Yes, we can.
Hello.
Hello.
हाँ, you can, na?
We can.
Okay.
Yeah, we can. The sound is good.
Just so you know, it's mic's on.
My screen is visible?
No.
No, we can't see it. We'll put your report bucket. We can.
They fixed it, yeah.
Well, because I've been talking with them for the last 4 minutes and there was no echo. So if it happens again, we can talk to the airports. Should I able to talk with them now? Should I try?
Hi, can you hear me?
We can, yes.
Joanna can hear. Poonam?
Yeah.
Poonam?
Hi Rohit, you are audible and visible also.
Audible and visible also. Now we need to
Just
put
give
this.
us a minute. Just give us a minute, Rohit, because Academy is sharing resume of the moderator on the screen. They will introduce the moderator and then we can take it ahead.
Poonam, just give him a second, please. Sorry.
Yeah. And then we can do that.
Yes, now the screen is being shared from the Academy.
Okay, thank you. This is Prajakta here. I will be on the back end from Academy of Nutritional Sciences if there is anything. Just quick thing, I will introduce Jayashree Paranspe ma'am. Jayashree Paranspe ma'am will introduce Rohit and then we can take it ahead.
I apologize. Can I just suggest you put it in presentation mode? It might look better.
Sure. One second.
Yeah.
This is okay?
You can just, yes, that.
Yeah, you must read, yes.
Yeah, this is perfect.
Okay. Jayashree ma'am, you're able to hear now?
Hello, can you all hear me? Because at least I am not able to hear.
Yes, we can hear you.
Yeah, you're audible. We can hear you, ma'am.
Yes, ma'am, we can hear you.
You can hear, but
Hello, Academy team. This is Poonam. Jayashree madam is facing some network challenges. She will log in again. She has advised us to start with the session.
Okay. So should we, okay, just allow me 1 minute. I'll speak to her once again.
Yeah. Academy team, I think we should start now.
Okay.
Yeah. So I would request Rohit to share his slides. Academy, please stop sharing the
We can
resume of Jayashree Madam, please. We can start with the session, and meanwhile, Dr. Jayashree Madam can join us.
Joanna, does it look all right?
Yes, it does.
Joanna confirmed yes. Yeah. Yeah, you can see the slides, yeah?
Yes, I can see the slides. Now is
Joanna, can you
the
just
first one.
stop to share, yeah? To finish this and still remain in the conference, I just have to stop sharing.
Right button.
Yeah, on the side. Okay, all right. Thank you. So I think we should start now, and glad that we are starting. Sorry about the few minutes delay. I understand there was technical issues in India. If everybody could please mute when I speak, and then we can take the questions at the end. So very interesting topic, and thank you again for inviting me one more time to speak at the conference. I hope it will be very useful, especially because this topic is at the epicenter of world health, and India stands in the epicenter of the epicenter. So as we say, India being the diabetic capital of the world, not just surely because of this big population, but also in terms of the percentage of people affected by diabetes and obesity or borderline obesity, just makes it a very, very important area of health and research to focus on. So today we are going to talk about diabetes and how could your fat storage pattern affect or increase the risk of diabetes. And without going into too many basic details, what I am trying to do is going to speak more about things that we can do to change the problems that we face, or what can we do to help people and control diabetes, control obesity. Since we have only about an hour, I'm going to focus on mainly fat related or obesity related issues that lead to improper glycemic control, and also fat accumulation, fat storage, and then how does it affect our hormones, and how do we get into a negative spiral of eating more, having an impact on your hormones, your brain messaging um, to eat more, and then the fat storage and bad lifestyle, and how all that culminates to obesity, borderline diabetes, and then eventually to type 2 diabetes. So we talk about this first introduction. When you introduce, you can clearly see that this slide shows waist to hip ratio, and it actually shows how you should look and how normally we look. So excess weight, including overweight and obesity, is one of the leading risk factors of type 2 diabetes. Excess fat can be measured by BMI, which is a known predictor of its complications. However, evidence shows that fat storage pattern is a stronger predictor of cardiometabolic complications compared to the BMI alone. There are two fat storage patterns: the android pattern, characterized by accumulation of fat in the abdomen around organs and associated with high type 2 diabetes risk, and the gynoid pattern, characterized by accumulation of fat in the lower extremities and, of course, subcutaneous fat. So, visceral obesity can be measured using the hip to waist ratio, or the waist to hip ratio, with higher ratios conferring greater risk. For the Asian population, the waist to hip ratio cutoffs points are lower as its population accumulates more truncal fat at a given BMI compared to Caucasian or the Western population, further increasing their risk to type 2 diabetes. 0.85 is for men, and 0.8 is the ratio for women. So, how can we measure the waist to hip ratio? First, the waist circumference should be measured by positioning the measuring tape in the midpoint between the subcostal and the suprailiac sides. Then the hip circumference can be measured by positioning the tape at the widest level of the hip or the buttocks. Lastly, the waist circumference should be divided by the hip circumference. Other usual circumferences include upper thigh and calf, which can be used to calculate the waist to thigh or the waist to calf ratios. They are measures of fat and muscle distribution, and higher inches have been associated with cardiovascular disease risk. So one is that the ratio itself is very important, but not just the ratio, but also the individual figures. When you measure the fat or the circumference around this area, those numbers become very important. Your circumference of the hip, circumference of the upper thigh, circumference of the calf, and the lower body extremities fat storage or circumferences are actually exceptionally useful when calculating fat ratios in women more than men. Skin fold measurements can be used to measure subcutaneous fat content, which then can be used to estimate body fat percentage. A few body measurements points can be used here, as seen in this figure, where we have those red marks. You can see those are great points to measure skin folds. The generic equation for adult men and women are shown in this slide. Equations for children and different ethnic groups have also been developed, but these two equations that you see here, percentage for body fat for men and for women, based on the four-side skin fold equation, is common, universally accepted way of measuring skin folds. So you have the circumferences and the skin folds, two measures. Both are very important, and they are more important than just calculating the BMI. And if you actually think about it, calculating BMI is a very technical thing. It can be done through a machine which you stand up on, and you can check your body mass index, and that is not really a measure of how healthy you are, because it doesn't actually give you the exact body percentage fat, both visceral fat and the fat under your skin. But by doing the waist to hip ratios, which is through the circumference measurement, or doing the skin fold measurement through calipers, you can actually get the level of fat that one carries. So you can be weighing very low, for example, for your height ratio, and you could be very muscular and having a very low body fat. That doesn't make you any weaker, and you could be within the decent BMI, within the right BMI range, but maybe carrying a very high body fat and low muscle mass. And that is not right if you have a normal BMI but a very high body percent fat. And hence, body fat percentage measurements are more reliable for management as well as treatment of obesity and eventually, of course, type 2 diabetes. So now I will discuss the mechanism that underpins the association between fat storage pattern and type 2 diabetes, all of which stem from the fact that the visceral fat has a differential expression of genes in phenotypically different and more metabolically active than subcutaneous and gluteofemoral fat, the fat around the hip and the lower extremities, while also being in close proximity to the vital organs. The progressive enlargement of adipocytes in the visceral fat leads to their dysfunction and apoptosis. This process triggers the release of reactive oxygen species and pro-inflammatory cytokines such as TNF alpha and IL-6B, which recruit and activate pro-inflammatory macrophages. This results in a systemic low-grade inflammation, as you can see in this diagram. The TNF alpha cytokine then activates proteins which impair insulin signaling by reducing phosphorylation of insulin receptors and IRS2, contributing to insulin resistance. In contrast, the gluteofemoral fat exhibits low macrophage infiltration and reduced release of pro-inflammatory cytokines, which plays a protective role in maintaining the insulin sensitivity, so reducing insulin resistance. Adipocytes, as you can see from visceral fat, enlarge primarily through the growth of adipocytes rather than cell division, which is thought to cause their dysfunction. As adipocytes accumulate excessive calories, their capacity to store triglyceride decreases, leading to an increased release of these free fatty acids. Additionally, Visceral fat exhibits high lipid turnover characterized by increased FA uptake and lipolysis. This further of fatty acids is stored, this extra fatty acids will be stored in other organs such as liver, muscles, pancreas, etc. In contrast, the gluteofemoral fat expands mainly through adipocyte division, making it less prone to apoptosis and the release of fatty acids. It also decreased the lipid turnover and is more responsive to insulin's inhibitory effects on lipolysis, reducing its ability to release fatty acids. So there will be less free fatty acids. So over time, it effectively traps the fatty acids, preventing their harmful accumulation in organs. Ectopic fat deposition leads to lipotoxicity in glucose regulatory organs. It induces toxic lipid production, including ceramides, which inhibit key insulin signaling proteins and upregulate proteins that dephosphorylate the insulin receptor, contributing to insulin resistance. These lipids also activate the NFKB pathway and promote reactive oxygen species, further impairing the insulin sensitivity and increasing the risk of insulin resistance. Lipotoxicity also drives mitochondrial dysfunction, reducing the energy generating capacity and increasing ROS, reactive oxygen species production, leading to decreased substrate oxidation and further fat accumulation. Lipotoxicity in the pancreas also induce beta cells dysfunction by increasing oxidative stress and inducing the beta cell death, which ultimately decreases their insulin releasing capacity. Mitochondrial dysfunction in the pancreas also decrease the stimulatory action of glucose oxidation on insulin release. All these different factors would lead to extra insulin resistance. Adiponectin is a hormone that is produced by the adipose tissue. Abdominal obesity is associated with significantly lower adiponectin, while gluteofemoral fat is linked with higher adiponectin. In the liver, adiponectin reduces fat synthesis and promotes fatty acids oxidation, leading to decreased fat content. Additionally, it inhibits the glyconeogenesis and glyconeolysis. In the liver and the muscle, adiponectin enhances insulin sensitivity by activating proteins in insulin signaling pathway. In the muscle, though, it also increases fatty acid oxidation, which reduces triglyceride accumulation. Adiponectin also suppresses the NFKB pathway and reduces the release of pro-inflammatory cytokines from macrophages, thus protecting against inflammation associated with insulin resistance. So another pathway of avoiding insulin resistance is reducing inflammation through inhibition of cytokines coming from macrophages. Therefore, the higher the level of adiponectin associated with gluteofemoral fat distribution contributes its protective effect against type 2 diabetes. So hormone control becomes very, very important. Now I'll discuss the interventions that we have seen or proven to be effective in type 2 diabetes, but also contribute to better glucose control and even remission of type 2 diabetes. So there's this study that was aimed to compare the effect of metformin versus lifestyle intervention that included weight loss, a healthy diet, 150 minutes of exercise per week versus a placebo on the incidence of type 2 diabetes or in pre-diabetic obese patients. After 3 years, it's a very long study, after 3 years, the lifestyle intervention reduced the incidence by 58%. Metformin reduced the incidence of type 2 diabetes by 31%, as compared to, of course, there was no effect on the placebo or very little effect on the placebo. So that study showed that lifestyle intervention, as in a healthy diet, a healthy, sustainable diet, enough exercise, good sleep, having enough water, etc., that can actually have a more preventative method or effect on type 2 diabetes than even the first-line therapy drug like metformin. So if you can see here, metformin effect is in the middle. Lifestyle has reduced the chances of diabetes much lower, and placebo, of course, had minimum effect. So you can see that lifestyle intervention is actually even better than just using metformin. But if you're using metformin and also recommending a good lifestyle, that would, of course, be working even better, working together. So the direct RCD aim to, this is another example, to investigate the effect of a weight loss program using very low calorie meal replacements, such as nutritionally complete soups, milkshakes, protein shakes, etc., on type 2 diabetes remission. We saw that weight loss of more than 10 kilos after 12 months resulted in a significant decrease in liver fat content, pancreatic fat content, and blood lipid levels, which show that metabolic pathologies can be completely reversed with lifestyle changes. Additionally, these changes lead to remission of T2 diabetes and and led to recovery of the beta cell function in responders. Although non-responders experienced a similar decrease in ectopic fat levels, they did not achieve type 2 diabetes remission due to longer disease duration, which is associated with irreversible loss of the pancreatic beta cells. These findings clearly suggest that the earlier lifestyle changes that bring about the weight loss are implemented, the higher probability of type 2 diabetes remission. There are also interventions in the GLP receptor areas. So GLP receptors agonist mimic the function of glucagon-like peptide 1 hormone that is naturally produced in the intestine in the response of food intake. Initially, they were introduced in the form of injections, but now more formulas have been developed, including liquid supplement forms, etc. They have been proven to induce significant weight loss, reduce blood cholesterol, and improve better glucose control. They inhibit the secretion of glucagon, which while stimulating the release of insulin, lowering the postprandial glucose of satiety, or the giving a feeling of satiety, which means it will reduce the postprandial glucose spikes. So they may help reduce blood pressure by reducing inflammation as well, and so they can influence the endothelial tissue function as well. GLP-1 agonists also act on hypothalamus, where they decrease appetite, therefore contributing to weight loss and associated with improved type 2 diabetes if you have type 2 diabetes. So you can see that there is a psychological effect that is running through the central nervous system, the brain, which is reducing the appetite, and that will impact the adipocytes, the tissue level. So there'll be less adiposity, there'll be less body weight, and there'll be reduced inflammation. But the actual and the other secondary effect is the control on the GIT, etc., along with lowering of the blood pressure. So it has shown that it can work in multiple different ways, although the major mechanism of action still remains through GLP-1 agonistic activity. It can be used in multiple ways, not just to avoid type 2 diabetes, but also treat type 2 diabetes, and particularly treating or having better glucose control through satiety and hormonal control. Apart from drugs and weight loss interventions, supplementation with micronutrients can significantly improve insulin resistance and blood glucose control parameters, including fasting blood glucose, HbA1c, and insulin levels too. Starting from chromium, which has consistently been shown to improve insulin resistance in RCTs as doses ranging from 200 to 1000 micrograms per day. Chromium also improves insulin resistance by activating the insulin receptor and downstreams protein participating in the insulin transduction pathway. This ultimately leads to improved insulin signaling and the translocation of GLUT4 transporters to cellular membrane. Zinc and magnesium are other two minerals with robust research from various different clinical trials supporting their protective role in type 2 diabetes. Both minerals participate in activation of insulin receptors and their downstream proteins, facilitating the GLUT4 translocation. Additionally, they both have anti-inflammatory properties, thus decreasing inflammation and its negative effect on insulin signaling and pancreatin function. Effective doses of magnesium start at 300 mg. 375 mg a day is the recommended daily intake or nutrient reference intake value. And zinc, the effective dose will be 20 to 40 mg, although the nutrient reference value for zinc is only 10 mg a day, but you can go up to 20 to 40 mg a day. In terms of vitamins, the number one vitamin for decreasing the insulin resistance would be vitamin D supplementation. It can decrease insulin resistance with higher doses of 200 to 4,000, 2,000 to 4,000 IU international units per day required in patients with excessive weights due to lower bioavailability. Vitamin D improves insulin signaling due to its immunomodulatory properties, whereby it reduces the activity of pro-inflammatory cells by lowering inflammation. It also decreases the pancreatic beta cell dysfunctioning. So it's very, very important vitamin. And people say that if you live in tropical um, countries like India, you don't need to take a vitamin D supplementation. I completely disagree with that, because to manufacture vitamin D within your body, you need a lot of sun exposure, and even that mechanism is not guaranteed to take place in the absence of other enzymes and cofactors that help the conversion of production of vitamin D or cholecalciferol, the active form of vitamin D. We also lead a lifestyle which is not very pro nature oriented. So in very hot countries, we often see that people spend long hours of the days protecting their skin against the sun, sitting in air-conditioned offices, homes, cars, etc. That would also restrict the time that you spend in the sun. And in the age of melanomas, I think I would rather have a patient more dependent on vitamin D supplement than just sunlight. B vitamins also, including folate and B12, could improve insulin resistance or improve insulin resistance by lowering homocysteine levels. So high blood homocysteine is not only a risk factor for cardiovascular diseases, but it also increases oxidative stress by decreasing insulin signaling. And lastly, antioxidant vitamins such as vitamin C and E have also shown to increase antioxidant capacity in patients with type 2 diabetes, thus ameliorating oxidative stress and improving insulin sensitivity. So the take home message from this is that fat distribution pattern can be measured, and BMI is not the best way of measuring fat distribution throughout the body. There are stronger predictors of than BMI, which are measuring body girths or circumferences and skin folds, which are very simple and very mechanical too. They're not too technical. The phenotypic differences of the visceral tissue render it more pro-inflammatory, in addition to having a greater propensity to release fatty acids, which can be stored ectopically. Gluteofemoral fat storage pattern seems to be protective against type 2 diabetes, as it serves as a metabolic sink for fatty acids, depositing the fatty acids, decreasing lipotoxicity in glucose regulated hormones. This is also associated with higher adiponectin levels, which increase insulin sensitivity and also preserve the pancreatic B cell function. And most importantly, last but not the least, is type 2 diabetes can be prevented in cases, and actually it's not some cases, in most cases, and it can be also reversed in some cases with lifestyle changes as well as medication. And as you saw that when we compared lifestyle changes to medications or frontline drugs such as metformin, we actually saw that lifestyle changes offered better protections against type 2 diabetes than standard pharmaceutical drugs. Hence, considering micronutrients becomes very important as well. And they also offer a solution to improving insulin resistance and blood glucose control biomarkers alongside a healthy lifestyle, which includes eating tidy, keeping your mind at rest, sleeping well, having enough water, and most importantly, keeping yourself active. A regular walk in the park, some aerobic exercise, about 150 minutes a week, alongside healthy diet could actually do wonders in the prevention of diabetes type 2, which is the major concern in terms of non-communicable diseases, and is the second most relatable or important cause of morbidity and mortality after cardiovascular diseases. So a very clear take-home message, I think, from this the various slides that we saw. We saw how to treat the patient, how to detect the fat distribution, and we also learned a little bit of or went over the intricate biochemistry of fat deposition, insulin resistance, improving insulin sensitivity, and beta cell function. And we have all of this referenced here in my last slide. So I request you to please go through all these references and read them once. I've tried to keep all the references to as recent as possible, possibly in the last 6 or 8 years. And they're each very useful, and they're mostly clinical trials. Everything I've said was clinical evidence-based. Um, so yes, thank you very much. Enjoyed talking, and we are open for questions now.
Yes, thank you, Rohit, for such an elaborate presentation. Sorry, I couldn't join earlier, but I know, I will introduce you once again to this gathering, because they have heard you earlier also. But your degree in pharmacy, although your special interest is in nutrition, must have helped them a lot. Many things they are aware, but biochemistry is something which needs to be repeated again and again and again, because that is ultimately, nutrition science is all about connecting the dots, the biochemistry and the nutrition. So once you understand the biochemistry, things become much clearer. And here I would like to share with you one of our experience. Since you know that I have been working in Nair Hospital for as many years, and Nair Hospital being part of MCGM, that is Municipal Corporation, so they understood the need for lifestyle changes which can bring about change in diabetes management. So we started it as a project. Now all the patients cannot reach these big hospitals. So we decided to take the dietitians to the dispensary level, and their patients were referred to the dietitian, and our dietitians did such wonderful job. And when they were when they saw the results, that even 5% of weight loss can bring about so much of change. So that was when these dietitians, it became a permanent posting, and we were able to increase the number of posts to almost 25 to 30 in the dispensaries. So that's a success story which I wanted to share with you. I'm sure.
Incredible, yeah, incredible. Very inspiring story,
Yes.
actually. And you rightly mentioned that everybody doesn't have access to, all the big hospitals where,
Yeah.
things are easily available. And that's why
Correct.
grassroots level work is most important. In fact, I always talk when
Right.
I'm, traveling abroad, I always say that, you actually know how well a country is doing economically,
Right.
or how progressive a country is by looking at the lowest strata. You have to visit the municipal hospitals, and you have to work with government hospitals to see what is the level of understanding, and what is the level of treatment being imparted to patients.
Right. And the best part is all this treatment is free of cost. So that also
Wonderful.
needs to be appreciated. That, yeah, coming back to your presentation, as I said, you very well explained. Now, for so many years, BMI has been our, go-to this referral to judge obesity. And in recent times, the BMI has become, the role model, because as we know, thin fat Indian is a very common concept. Now people have understood that just because you have high or low BMI is not indicative of obesity. And there are many conditions, for example, say like GDM, where you cannot really calculate BMI, or for that matter, an athlete or someone who is like what those where they need to be muscular, or somebody who is muscular, is BMI just because it is high is not an indicator of obesity. So
You're
good
so
that
right.
we,
Yeah. Yeah.
yes,
And also somebody on the other side, somebody who has a thyroid dysfunction.
absolutely
How would you say that their BMI could be an accurate measure? Because when one gland is not operating, the hormonal effect that it has on all the other systems
correct,
make the body composition so much dependent on that underlying condition that you may feel that the person is obese or too thin based on the thyroid levels, and particularly if it is a genetic thing, but they may
correct,
be in worse shape than you can actually think that they are, because they may have a okay-ish BMI, and you may think that because the BMI is okay, they don't need treatment, but their muscle
right,
to fat ratio may be completely off. And
correct,
for years, doctors and dietitians did not focus as much on those ratios. They focused mainly on the BMI, and they said if the BMI is within the range, then the patient is okay, all right. They may probably not need therapy. But actually, we saw that in these recent
yeah,
years, that those with very normal BMI are more susceptible because they are less looked after.
correct, absolutely. So, having said that, because then BMI, if it is not right, it can uh, kind of we go in a very wrong direction in terms of planning their lifestyle. So, because just because somebody's BMI is more, there will be unnecessary calorie restriction, or even when we are deciding about the protein composition of their meals. So, I am sure that your presentation has made it very clear to use BMI whenever and to whomsoever it is possible, because that is the new go. Also, although you have explained during your presentation, I would like you to talk little more on waist hip ratio and waist circumference and insulin resistance.
Yes, they are all very related. I mean,
Yes,
I basically only depend on the ratios, and as I said, 0.85 or zero point 0.8 for women,
right,
is a standard, and but a body build of a Asian would be a bit different to someone in the Middle East, or a Caucasian person or an African, and those ratios differ. But generally, what you saw in my slides are generally
yes,
acceptable ratios. Why it is very important is because of a simple reason, and that is, by BMI, you cannot actually understand what is the fat level that is stored. Both under the
correct,
skin, BMI doesn't tell you that, and
yes.
also what is the organ fat. See, liver-related diseases and liver-related toxicities, such as non-alcoholic liver syndrome. Why does it happen? It happens because predominantly that your liver is storing excess fat, which may not be
Absolutely.
related to alcohol consumption because it's non-alcoholic fatty liver. And when you look at most liver conditions in, for example, in Middle East, because they're Islamic countries, they drink much less alcohol than the rest of the world, but they have a very high percentage of liver toxicity and non-alcoholic liver syndrome, and that is because of very excessive levels of carbohydrates in the diets, which are not utilized to
Right,
perform any physical work, because life is
right,
quite sedentary. These regions are extremely hot, and India is not an exception. Also, India also comes very close to that, a very hot country, and 8 9 months of heat, and then 2 3 months of milder temperatures. The eating habits are very carby. We have carbs all around us, and that leads to fat storage. And it is a cascade, isn't it? When you do not utilize those carbs, you're triggering your hormones to give you a false message of eating more. When there is more insulin, you need when there is more sugar in the blood, you need more insulin. When there's more insulin, you think that
develop
you need more
resistance.
food.
Yes,
So it's just food to insulin, and anything in excess is going to cause resistance. It's like the antibacterial antibiotic resistance that people develop with too much exposure to antibiotics is very, very similar thing. At the end of the day, it's a hormone, and any hormone produced more than necessary would cause would cause resistance. So yeah, coming back to this slide again, the percentage body fat, this is how we calculate. This is what I believe in. It's a very, very simple formula of skin folds and square of sum of the skin folds, and then you times it by, you use the factor and times it by age and times it by the for skin folds, and for circumference you just have to measure it. But the best thing about skin folds is using those calipers. If you use those calipers at those points, you see the under the chest, under the tricep, abdomen, lower middle abdomen, on the thigh, and on your calf. They are fat accumulating areas. That is where the adipose tissue is. That is where the fat, unnecessary, unutilized fat is stored. And when you see a result in your patients, when they go on a healthy diet and when they start, exercising, etc., you actually also see those areas changing. So they are very, very good parameters. When you start, I've even written exactly where to do that: mid axillary, suprailiac, mid thigh, abdominal, tricep, bicep. These are the areas which also respond very quickly. And this can be seen even without any test. You can see it with the naked eye. You can see it in a picture, those fats area getting fats releasing from those areas. And one of the important point I would like to say here is, we should not forget that whilst you do the BMI, you totally ignore muscle mass.
Absolutely.
And that is why we see so many cases of sarcopenia, because we think that, oh, because I am weak, or I'm a little fat, or I have marginal diabetes, or I have, I don't know, a condition, I should not be pushing myself to build muscle because I don't need muscle after a certain age. I'm not an athlete. But these are all myths. Actually, if you're not an athlete and you have not been exercising all your life, you need muscle all the more, because your body has no muscle memory. So you have to build that muscle memory. As you get more and more prone towards obesity and diabetes as you age, as you cross your 40s or 50s, you need the muscle more than any other time in life. If you have stronger muscle, relatively stronger muscle, there is also a possibility that you will have less fractures, because the muscle is always going to protect the bone. Imagine a bony structure with fat accumulating only in some areas of the body, not protecting the most important joints and bones that are likely to get fractured. You're going to have falls at, once you age, and you're going to be exposed to more bone injuries in the absence of muscle. Muscle is also constantly fueling the bone. It's also putting the load on the bone. It's also making the bone stronger. In the absence of muscle, that resistance is not there on the bone for the bone to do any work. So the bones are automatically going to weaken. For example, in menopausal women, the menopausal woman is losing calcium. If she's losing muscle at the same time, that lack of calcium will make the bone loss faster and more. In the presence of muscle, that bone mass reduction will be much slower, in spite of the low estrogen levels. So for all these reasons, it's important to calculate your muscle mass and calculate your fat mass. Keep the fat low and keep increasing the muscle mass.
Yeah. Actually, the Indian way of diet, the concept of eating protein, we are continuously concentrating on carb eating. So I feel as Indians, and I mean, I think you are Maharashtrian. So we believe in, so we believe in feeding, and all our love is shown through feeding. आग्रह करून जेवायला घालायचं.
Yes.
So I think we should change our ways of feeding people, and it should start right from childhood, because I think that is the time when we should be addressing these issues, because you grow up as a chubby child, and chubby child is always considered to be a healthy child, or khate pitte ghar ka bachcha. I mean,
actually they use that word. No, they don't say that my child is fat. They say that my child is little healthy.
Right. And like, you are not even supposed to count how much he is eating. So all this awareness needs to be created. What happens is, normally these discussions remain within the four walls of the scientific community. We need to take it to the masses, and that is what we have been trying to do. Now, besides my own questions, I will just ask you one last question, and then I will go to the questions which are being asked in the chat box. Nowadays, there is this Ozempic, that fad is there. or some semaglutides and all these. And since you are from pharma, I feel you are in a better position to answer that. As a dietitian, I am very convinced that lifestyle modification is the thing. But yes, in sometimes do these pharmacological agents besides pediatric surgery have a role to play? And are we overdoing it, or I mean, what are your views on that?
So unless you are a very high level of T2 diabetes patient where glucose control is off the charts and you're extremely obese, I wouldn't use a GLP agonist of any sort. Ozempic is one of them. Okay, and why? There are two aspects. How safe? If you ask me, how safe Ozempic or semaglutides are, they are safe. If they were not safe, they wouldn't be in the market. Right.
Correct.
So they've gone through all these FDA approvals and UK MHRA approvals and Anvisa from Brazil and TGA from Australia and the Indian FDA and all. Every health regulatory body has approved them, so they are fine. But the usage is very specifically defined for type 2 diabetes, where other treatments have failed, and they should be used there. So there are negatives as well. That is why they are to be prescribed in a certain, group of patients which are at very high level of type 2 diabetes, very high level of, glycemic imbalance, very high level of obesity. What people are doing they are using it like a cosmetic drug to look
Absolutely.
better, to lose fat, to look better, to eat less. And that is not good. And I'll tell you why it is not good is because number one, um, Ozempic or any GLP-1 agonist have a very high gastric emptying time. Generally, the safety of a drug as a pharmacist would be seen from its gastric emptying time. For how long does it stay in your system? If the drug is staying in the system for very long, it will have negative gastrointestinal effect, and Ozempic does the same. It has negative gastrointestinal effect, i.e., it can cause gastric paralysis. It can cause
gastroparesis.
yes, gastroparesis, which is gastric paralysis. It can
Yeah.
cause inflammation in the pancreas. It can be responsible for pancreatitis. It can have an effect on your heartbeat. It can cause tachycardia, making the heart work faster and beat faster. It can cause hypotension. So because it is also a drug for hypertension, right? It is also used for treating hypertension, but too much excess of use when there is no hypertension can cause the blood pressure to drop, hypertension. It is definitely related to thyroid carcinomas, medullary thyroid carcinomas. And if there is any family history of MTC, then I would not recommend, anybody should recommend Ozempic to a person of that background. And then the mental effect is also very important, that because it works on the central nervous system and works on the brain and it works on hormones, it can cause a sudden loss in your appetite, but it can cause a relapse, because when you come off, there would be withdrawal symptoms. And one of the withdrawal symptoms would be going back to the unhealthy eating style, because you've just lost too much too fast through stimulating your neuroreceptors. So that I think because of all these reasons, Ozempic should not be used as a cosmetic drug just to look nice or lose weight. When we have easy methods of doing it, if you just eat well, and well as in not in some kind of crazy diet, but just watch your calories in terms of low fat, moderate carbs, and high protein, higher than you normally take. Sleep well, drink enough water, and do some aerobic exercise. Like 30 minutes a day of aerobic exercise is 150 minutes a week. 30 minutes a day is only 5 days a week. You have to do 150 minutes a day. That could give you better glycemic control and better functioning beta cells in just 3 months. And you saw that in the study. The study was extrapolated for 3 years because it was done on a very large group. But you can ideally see these kind of effects in 12 to 15 to 20 weeks max.
Right. The problem is we are always searching for quick solutions. And we feel whatever is healthy is very difficult. And now with the kind of lifestyle that I should say your generation is leading, So maybe that's why they get, carried away by this. But what I like the most is when you said that, yes, lifestyle modification is here to stay, and mainly people don't think what happens afterwards once we stop the treatment. And you have, and even when you are on Ozempic or any other these kind of treatments, lifestyle modification anyway has to be done.
Yes.
So it is not as if that just because I'm taking these, I can eat whatever I want. So that message needs to go to everyone, and when you are suggesting to your patients as well. So that was very nice, and I was sure that you will be able to explain it better, being a pharma guy. Coming to the questions asked by our participants, someone in the chat box has asked, what is your opinion on impact of body fat percentage and neurocognitive function? Yeah.
So there is a very good question, and there is a very good study I could refer to. I can't remember the exact date and where it was, but there is a study that you can look up on Science Direct, PubMed, whichever scientific database you have access to. There was a study that looked at the size of the brain and the number of neurons. And if you just Google it, you will find that study. It showed that people who had a higher BMI or higher body fat ratio had brain size of 10 years more than your age. So they looked at the brain size of a 40-year-old with a good diet and a good lifestyle and a good BMI and a low body fat content to a 40-year-old brain of a person who was having a bad lifestyle and probably was smoking and drinking as well, and high body fat level. And they saw that the brain aged by 10 to 15 years. So this 40-year-old brain looked like a 65-year-old brain, which was based on the size of the brain and also number of cells of the brain. So there is a direct connection on the CNS, as you see. Even GLP-1 receptor agonists have they directly connect to your CNS. So they have effect on your GI and other systems of the body, but the primary effect is on the CNS. And without the CNS being activated, neither of the GLP-1 receptors agonist would work, nor the lifestyle will work actually without stimulating the CNS, without stimulating the brain. So yeah, the direct scientific evidence is that reduction in number of brain cells, neurons, as well as the size of the brain tissue has been seen in people who follow an unhealthy lifestyle, leading to a higher body fat content.
Yeah. Thank you so much. That was really well said. There is another question. Isn't surgical intervention better for those who are not able to reduce weight by diet and exercise? I think that drugs cutting you have answered. It says it is too high in cost. Aren't they good source of reducing weight? And indirectly, we are reducing diabetes. Basically, she's asking about surgical intervention as a way of fat loss, or rather obesity, decreasing obesity. So what's your take?
So it's a very relative thing, like I said, for Ozempic is good or bad. It depends on the context. If you have a very high level of glycemic imbalance and a very high level of obesity, and you need to bring it down immediately because it's life-threatening, yes, Ozempic is a safe drug for them. Should it be used as a cosmetic drug? No, it shouldn't be. The same with a bariatric surgery. If you surgically stitch the stomach, it's going to fill in quickly and you will eat less, and eventually you will have an effect. But even that has to be maintained, because a lot of that is related to the relation that you have between your serotonin production, your cortisol levels, and your glutarate concentrations in your brain, as well as the gut, because the gut and the brain hormones are so interrelated that this effect will not last long unless you have that other control, which is just generally eating well and all that. So about being yes or no, if it is required, if you're so obese that it is life threatening, then that the BMI about 35 and stuff, you call them extra obese, 35 to 50, you can die. Then of course bariatric surgery is fine. I'm not very a big fan of fat surgeries, which are also called as liposuction, where you suck out the fat,
Absolutely.
because that has a long-term bad effect, because you may you may then deactivate the fat cells. You may deactivate your adipose tissue completely because of these sucking of the fat out, and it may make you it may make you older at cellular as well as a superficial level as well. And that is also one of the things they call it uh, bariatric face, or an Ozempic face, when your face
Right.
falls. Yeah, when you
Correct.
lose when you lose too much fat from under the skin, it makes your skin sag, and it makes it
Tag.
yeah, look very bad, because tightening of the skin again takes a very long time if you do it naturally. I know there are surgeries to do that as well, but if there is no good and bad about this, if bariatric surgery is required because you are in a life-threatening situation, then yes, surgery is good. But if you're just doing it because you don't have control on your food, and you can't adopt a healthy lifestyle, then the recommendation is no, don't do it, because you cannot live a healthy life. It's much easier to do everything naturally without exposing yourself to too much of drugs or surgeries when it is not necessary. Don't do it cosmetically. Medically, of course, it is
Yeah.
safe.
So basically, what you're trying to say is slow and steady wins the race.
Absolutely, absolutely. And
Yes,
it is
but
more
in a
sustainable, it's sustainable.
uh,
Any diet or
correct.
any treatment you take has to be sustainable. You have to be able to sustain that lifestyle, otherwise you go back to normal. Hence, dieting
Yeah,
is not good. A lifestyle change,
absolutely.
discipline in your lifestyle goes beyond all this.
Absolutely. Because even after bariatric surgery, we have seen so many patients going in relapse, and that is actually more frustrating because they have spent so much of money, effort, and they have all their hopes pinned. This is going to solve my problems. But as you rightly said, when it is life threatening, yes, you should do it, but no crash diet is going to help you, and mainly it is not sustainable. So you should always aim to do something. As like now, we also say that there is nothing called fat loss diet, diabetic diet, all such things. It is lifestyle modification,
Yes,
which
and that is just
works
equally important for a non-diabetic as well as diabetic.
absolutely, and it should start right from childhood, because
Yes.
we are seeing childhood obesity. I mean, it is so much in across all financial groups. I mean, it is not restricted to only those who are, well-to-do families, yeah, whatever. So, because you can discipline someone right from childhood. Suddenly, if you
Yes.
decide, it is very difficult. So, we, like, as a mother, I would say we need to learn to change our ways to pamper. And as parents, also, the reward should not be in the form of food, right?
Absolutely. Yes. Very right.
Now there is, yeah, someone else has asked, it's a very good question. Nowadays, we are talking so much about gut microbiome. So, what's your this on gut microbiome and insulin resistance?
So they are related as well, and it's a very good question. The gut microbiome has to be healthy. Now, why is it not healthy? I mean, the main question is, don't we have natural mechanisms and processes in the body to maintain that gut microbiome? Do you need to take a probiotic supplement? Would be a natural question in people's mind. Yes, you have enough mechanisms and processes in the body to preserve your gut microbiome that you're born with, but our the way we eat and the way we treat our GI also influences our gastric emptying, what we throw out. On a daily basis, we lose millions and millions of good bacteria through excretion, and the loss will depend upon the kind of food you put in. So that is a very deep topic in itself. To come back to the question and answer this question in short,
Yeah,
is that gut microbiome has a lot to do with how your brain functions and how your metabolism functions. And for that, you need to have, in today's world where we don't eat much healthy food, we have a lot of trans fats instead of poly, long chain poly, saturated amino
Medium
acids
chain
and
fatty acids. Yes.
fatty acids. I mean, long chain is of course much better than medium chain also, but we don't have either. We have more short chain, and we have trans fats and saturated fat consumption more than polyunsaturated long chain fatty acids. In that scenario, a probiotic supplement goes a long way. But you should also be very careful of what you recommend. If you do not
Right.
have a certain CFUs and a certain right kind of probiotic combination, those probiotics that are available anywhere off the shelf may not be very useful. And another way of looking at it is your digestion actually starts in the stomach, and the
Right.
probiotics that you get is for the
In the
intestine, because
intestine.
the microbiome is in intestine. But if your stomach is not healthy, you will anyway struggle. Your microbiome may be there in numbers of CFUs, colony forming units. It may not be able to function. So what I really recommend is, if you're taking a probiotic supplement, also take an enzyme product that makes sure that the basic enzymes, the proteases, the amylases that are required for breaking down of your proteins, carbs, etc., are also fed to the stomach, to keep the pH healthy, to keep the gastric production healthy, and timely production of gastric acid as soon as you eat, etc. When your stomach digestion is good and it is complemented by your microbiome in the intestine, that's when your gut is going to be very healthy. If your stomach digestion is not good, and if you're just taking a lot of probiotic supplements, yogurts, etc., to feed your intestinal microbiota, it's not going to be helpful a lot, because a lot of food gets processed and broken down in the stomach itself before it reaches the intestine.
Right. Thank you. And I also feel that each one is born with a certain microbiota. It is like your fingerprint. So
Yeah.
what happens is, because of this so much of fat accumulation and faulty lifestyle, there is something called dysbiosis. So that's why simply taking probiotic off the shelf is not going to help, because there are specific strains, and this is still such a new subject that just going for probiotics is not going to help. And the composition of your diet, how much fiber you are eating, and how much fat you are eating, omega-3 fatty acids, all that is going to decide the quality of your gut microbiome. So again, I mean, everything brings back to healthy eating, pattern. If your food composition is good, with fiber, protein, carbohydrate, water, and fat in right proportion, I think that should not be, that will do the trick. I will take one more question from someone. They have asked, she
I'd
has
just like
asked,
to add something to your gut
sure,
dysbiosis point.
sure,
That talking
sure.
about fiber,
Yeah,
it is also very important to understand that each time we take a protein source or a fat source that is non-fiber bound,
right,
protein can be also fiber bound or non-fiber bound. Carbs are also fiber bounds like vegetables, and non-fiber bounds that come from grains. Each time we
right,
consume a food that is non-fiber bound, you are starving the gut bacteria, because
correct.
fiber is prebiotic, which is a food for your probiotic
Food,
bacteria. So
yes,
each meal you think like that, that the more grains you add to your food, like rice, wheat, anything, you're feeding your stomach, but you're starving the gut. You're starving the
correct.
gut microbiome. Each time you have a fiber
To
bound
add,
carb or fiber bound protein, which is
yeah,
vegetables or vegetarian form of protein, etc., you are
yeah,
feeding the gut bacteria. So it's just a
correct.
simple mechanism to remember.
Absolutely. One more question before we wind up, because I think otherwise we will be overshooting the time, and you are a busy person. Uh, but if you are ready to answer more questions, I don't mind shooting more questions to you. But there is one interesting question she has asked, that if a probiotic is to be taken along with, and if you're taking it with, say, vitamin capsules like B12, D3, magnesium, can you take these together, or there should be a gap, or what?
You
I
can
mean,
take
what
it
is your,
together. No, absolutely. The
Yeah.
the probiotic should not be taken with antibiotics. This is the only contraindication they have, which is also not a contraindication. It's just a precaution because
Right.
sometimes they are not very target oriented, the antibiotics, and they can destroy the good bacteria along with the bad
Yeah.
bacteria, right? So that's the only thing. Otherwise, with the vitamin supplement, vitamin minerals that we mentioned in the slides as well, magnesium, zinc, chromium, D, B12, B6, B3, B1, these vitamins, zinc and vitamin C, E, these are the standard vitamins and minerals that you should be taking for a healthy gut and as a part of your healthy diet because you're also deficient in these micronutrients. They can be taken at any time, preferably on a full stomach. If you take it on the full stomach, it is good for both the probiotic capsule or tablet that you take as well as your vitamin tablet that you take.
Yeah, thank you so much. And once again, I will
Pleasure.
say we are sorry for all that mix-up which happened earlier. And but nonetheless, what ends well, I mean, should be appreciated. It was good interaction, and I'm sure that you also have enjoyed our interaction. And we will continue to have many such programs. And on behalf of Academy of Nutrition and everyone, thank you so much. And for all those who attended, thank you once again. And if you have any queries, I'm sure he will like to address these queries. We will send it to him on mail. And yes, thank you.
Thank you. Thank you very much.
Yes.
Have a good day, everyone.
Yes.
It's a pleasure talking to you and
Yes.
wonderful questions as well. Thank you. Thanks.
Thank you so much.
Thanks. Bye.